welcome. My name is Matt Rahn. I'm the director of the Standards Division at the Office of National Coordinator for Health IT at the U.S. Department of Health and Human Services. I always do the long-winded way of saying it, but it's really HHS ONC. And then I'm going to let Dan introduce himself.
Hi, everyone. I'm Dan Vreeman from HL7 International. I'm the Chief Standards Development Officer. HL7 is a nonprofit organization that creates interoperability specifications to improve data sharing among health IT systems.
Great. So thanks, Dan. Very delighted to be here. Thanks to Sandy and team for inviting us to talk a little bit about FHIR and how it's been included in recent regulations over the last few years. So I'm going to talk a little bit about that, and then turn it over to Dan to talk a little bit more about the specifics of FHIR and how some of the things we've done to help support the implementation and adoption of FHIR. So just a little bit background about ONC. It was founded in 2004 by executive order and in 2009 by statute. And then we are charged with formulating the federal government's health IT strategy and push towards the interoperable nationwide health IT infrastructure. So in the HITECH Act of 2009, one of the main things that came from that is the certification program of certified health IT products. So through CMS programs and other programs, you're required to have a certified health IT product in order to get funds from those programs. And so as of now, ONC certification covers EHRs used by 97% of hospitals and 86% of ambulatory providers. Fast forward to the 21st Century Cures Act that was passed in 2016. It did have a few specific things for ONC around information blocking, standards that require access to APIs without special effort, and then TEFCA, the Trusted Exchange Framework and Common Agreement. And I'll talk a little bit about that, but there are a ton of other sessions. Yesterday, Elise Anthony, our Office of Policy Director, talked a little bit about that, but TEFCA is also something you're going to hear a lot about in the coming months. So some of the key areas of focus at ONC right now are to build the digital foundation via data standards and address those gaps in health IT. Make interoperability easy via things like TEFCA and APIs. Promote information sharing. Enforce the information blocking rules set forth in the Cures Act final rule and updated recently in our HDI-1. And then through our HHS Health IT alignment policy. This came about, I'll talk about a little bit about this. On the right side, you'd see it came about in the 2022. This allows ONC to work with our federal agencies to ensure that there's alignment across all the different projects going on. In this case, FHIR, one of our big projects that we've been working on over the past few years is called USCDI Plus. And so I'm not going to go super deep into USCDI Plus, but that is something we've been working on, and those specific use cases that agencies might have in addition to US core data for interoperability, those are things we work with them on. And then lastly, ensure responsible use of digital information around areas like transparency such as AI use, which AI, I think, is the number one thing around this whole conference. There's AI in literally every booth. So I'm sure you're hearing a lot about that. And so on the right, you can see some of the policy levers that we've been utilizing over the past few years, and then what are coming up. So we recently released the HTI-1 rule regulation in mid-December, right before our annual meeting. And then it actually went out on the Federal Register at the beginning of this year and goes into effect March 9th of this year. We are also working on a second regulation. Date is TBD, but the plan is for 2024. But it's essentially updating some of the certification program requirements that we have around FHIR and USCDI, so updating to new versions. And then TEFCA went live in 2023. There is conversation. The plan is to go live with FHIR Exchange with TEFCA this year. And then there's some of the other levers via CMS and OIG reporting. So some of the key moments that have kind of spurred this FHIR moment here is in 2012. I think the initial presentation was at HL7 workroom meeting by Graham Grieve, I assume. I'm just kidding. So thanks to Graham, he is about to depart on some year-long trip in Australia. And then in 2013, there was a JSON report to call for the use of public APIs. And then the first publication of FHIR in 2014. In 2015, we did come out with a rule that included API certification criteria. We did not name FHIR. It was still a little too new, but we did require that there was a functionality for an API. And then in the 21st Century Cures Act, as I already mentioned, that they did require availability of an API without special effort. And then 2017, FHIR Release 3 was published. And then 2020, May, we released our Cures Act final rule that was based off the 21st Century Cures Act that did include a criterion for patient and population services via API. And that did require FHIR US Core 3.1.1 at the time, based off of FHIR Release 4, which is normative. And so I've talked about the FHIR API requirement without special effort. You know, the goal is we want to be able to use these APIs on our that give us the same functionality, like using your bank, buying stocks, ordering meals with your phone. We want that same functionality for our providers and patients to have the similar experience with their healthcare system. And so, as I mentioned in the 21st Century Cures Act, again, I'm repeating myself a few times because it's just more clear that, you know, it was something that was very much pushed heavily, not only by Congress, but by us as well. So we did add, so in the Cures Act final rule, we took steps to prevent businesses and from taking technical barriers to information sharing. And then as of December 31st, 2022, all certified technology developers, they're required to deploy a standard FHIR API for individual and bulk access across their entire customer base. So every provider should have access to a FHIR-enabled system. And you know, this was our hope that it would create a climate for innovation as apps can now be developed and that they could work across the entire EHR system. So looking ahead a little bit in our HTI-1 notice of proposed rule, we had a few RFIs and they asked a little bit about future FHIR functionalities like questionnaires, scheduling, smart health links. And so we're looking at those things and figuring out how do we best include those in a certification program in the future. So again, the foundation for FHIR-based exchange over the last few years started with the ONC Cures Act final rule, and that was just base FHIR API for individual and bulk access. There was some CMS interoperability rules around patient access to API, provider directory API, and payer-to-payer data exchange. And then we've come out with HTI-1 and are about to come out with HTI-2 at some point this year, no specific date. And then we've announced recently that TEFCA will have a facilitated FHIR exchange go live tentatively at some point this year as well. So there's a lot going on, a lot of different work going on. Different agencies are working on a few different things around FHIR specifically. And our job at ONC is to make sure that there's alignment across those different initiatives. So I just put this slide on here, just kind of show there's a few different certification criteria that were updated in HTI-1, but specifically on the left side, you have US Core Data for Interoperability version 3 and the CCDA Companion Guide 4.1 and US Core 6.1. So US Core 6.1 is the FHIR implementation guide that allows for vendors to implement USCDI version 3. And then on the right, there's a few different criterion. Specifically around FHIR is the G10 criteria that we did update in HDI 1. You got the picture? All right, and I threw this in because this is USCDI version 3. HDI 1 does include this as the update to the baseline of which USCDI version by the end of 2025. And in HDI 1, we did update the US Core Implementation Guide to 6.1.0. And just to plug USCDI, draft USCDI version 5 is open right now. So if you want to comment on that, please do. Just wanted to highlight some of the different things that have been going on across the different agencies. So right now we're working with HRSA on their UDS Plus reporting. We're going through some testing and onboarding of different vendors to be able to, for federally qualified health centers, to be able to report the required reporting to HRSA via FHIR. We just published a implementation guide in December, the UDS Plus implementation guide on the FHIR Foundation website. And we've been going to FHIR Connect-a-thons to help improve that. And then there's a lot going on with CMS, as you can see there. I mean, but we work with them regularly. We coordinate with them on which standards we're going to be putting in based on FHIR into our rules and vice versa. And then we've been working with CDC on helping improve the public health reporting. They have their data monetization effort as well. We're very much focused with them to make sure that it is easier to do the public health reporting at some point in the future via FHIR. So these are just a few different things that we've been doing. I've taken more time than I expected already, so I'm going to turn it to Dan. But I just wanted to highlight some of the different initiatives at HHS. We also do work with VA and DoD and the firm on different FHIR-related solutions as well. But I mentioned USCDI Plus earlier, but through that USCDI Plus is where you'll see some of the engagements that we've have with HRSA, CDC, CMS, FDA, and NIH, and among others. But we're very much excited. I was joking with Steve Posnack, my boss, the other day that the U.S. is a FHIR-first country now. I'm just kidding, but we're very much pushing FHIR because we do think that it is going to make it long term. It's going to be better for the providers and the patients to provide the best care that possible. Oh, and then I have TUFCA FHIR support at the top. There you go. All right. I'll hang around after if we have any questions.
Perfect. Awesome. Well, it's a privilege to share the stage with my colleague Matt here. As you can see, the coordination between ONC and the industry is really critical to reaching their policy objectives. And we really believe, like Matt alluded to, that open data standards, and FHIR in particular, really set a foundation for innovation, unlocking new capabilities, new digital freedoms that are fun to start to see take place and take shape, both here in the US and around the world. But it is fuel because it unlocks the ability to have an app economy where both patients and providers can select functionality that meets their workflow and integrates into their existing systems, for agencies such as the government to be able to interact in a sort of a seamless way across the nation, and a whole host of other things. And so to give you a sort of a glimpse at where that foundation is building, I'm showing here a screenshot that is sort of the live reflection of the work that Matt has talked about, these milestones that have taken place over time. This is from ONC's Lantern site, showing the live FHIR endpoints that are now sort of in production and ready to receive requests around the world. And this is actually sort of truly remarkable when you think about the capability that it unlocks to really design new clinical workflows, to have more seamless integration between different participants in the health ecosystem than ever before. And so we're excited to sort of be on this journey together. I also wanted to highlight how the collaboration between the ONC and agencies like CMS are really working together building on and reflecting the movement that the industry is taking in adopting interoperable solutions. And so the CMS 0057F rule that came out around interop and prior auth was just published in January, I believe, and reflects sort of these new capabilities that are emerging, focused on payers providing a set of 5 different APIs that are based on FHIR. And what I am showing here is sort of on the top level, you can see sort of the required APIs across those different things, the patient access, the provider access, provider directory, payer to payer, and prior auth, as well as the set of implementation guides that are produced to help tailor the use of FHIR for particular workflows or applications. And you'll notice that many of the names in that list of IGs start with DaVinci, a FHIR Accelerator program that gathers together stakeholders from across the community, payers, providers, health IT vendors, and others who are interested in working on these problems. And so the output of that consensus-driven standards process is what's kind of setting this foundation. And as you sort of put some of these pieces together, you see, well, of course, there are many, many different kinds of actors in the US healthcare system, but we have a foundation, say, with the certification program for health IT that, electronic health record systems around the US are now required to be using these APIs. We have what CMS has now done, sort of setting the stage for payer APIs. That really is unlocking these other participants to use a common framework for exchanging data via FHIR. So for those of you who have worked on this problem for a while, you realize that you're never really done. And that's not necessarily a bad thing. We keep unlocking new capabilities as we go. We also keep encountering new kinds of information that we understand in different ways that are relevant to health information, whether that's genomics or social determinants of health or climate data, et cetera, that we have to sort of keep working on this problem. But I wanted to illustrate for you how if you are maybe a couple steps removed from core standards development and you see, okay, they talk about FHIR, but then they talk about these implementation guides, how do those things actually sort of work together? So I tried to put together a diagram here that illustrates some layering of capabilities or more specific building blocks that get put together to solve a particular use case or workflow. So on the bottom layer, you can think of the sort of core FHIR standard as a platform specification useful for lots of different kinds of workflows and use cases. You can combine those different aspects of FHIR with some other capabilities represented in standards that are part of sort of a product portfolio, including things like CQL, the clinical quality language, or bulk FHIR, the ability to get large piles of data represented in FHIR at once. The smart app launch sequence, which allows a way to connect apps to electronic health records, and capabilities from CDS hooks to connect external decision support technology, whether AI or otherwise, into the workflow of electronic health records, et cetera. You have a lot of building blocks that are standards-based that can allow you to create new capabilities. In addition, on the right side in the green there, you see a couple of additional framework possibilities. One that I'll mention is structured data capture, which, as Matt described, sort of forward-looking, thinking about better use of, more appropriate use of, wider use of, rather, questionnaires. This capability talks about more advanced types of questionnaires, including pre-population and the sort of more responsive design, et cetera. But at the core of that, right, we have profiles and documentation such as the US core, which is really the US national sort of baseline capabilities, tailored use of FHIR for use in the US context. And then around that, these other implementation guides point to and derive from that US core base implementation guide to help work on or address problems such as prior authorization. Those combined with other kinds of implementation guides that help us work on things like, how do we address infrastructure things like directories? When we want sort of national directories or even large organization directories, we need to sort of have a common way of representing that. And so these different sort of solutions or implementation guides are all building on some of these more fundamental building blocks. And as a bit of a preview or some thought-provoking things, you might see on the left-hand side of the screen some parts of FHIR that maybe are less familiar to you if you've really kind of heard about FHIR in the context of EHRs. This is more the knowledge representation aspect of FHIR, which is a little bit less widely known, less widely adopted, but we're seeing a lot of interest, including with folks like the WHO, about using common representation of clinical knowledge and using FHIR as a model for doing that. So more to come on that. But to show how sort of this pace of policy making and standards development is really sort of a well-coordinated cycle, I wanted to illustrate on this slide sort of how those things work together. Now, anything that's beyond today is forecast, not a promise, just a forecast to sort of carry the pattern forward a little bit. But what you see here on the top line are the corresponding versions of US Core, which US CDI, which Matt described as being core data for interoperability, and the complementary FHIR implementation guide version known as US Core that helps implement that particular version of US CDI. And as ONC has gotten into the cadence of yearly updates to US CDI, those are reflected in updates to US Core as well. And what the group within HL7, the US Realm Steering Committee, has agreed is that we're going to not make a version of US Core based on FHIR Release 5, which came out last year, and looking ahead to sort of set the stage for what we anticipate to be R6 as a new baseline normative version of FHIR. When the time comes, when that's published, we'll sort of jump there. But you can see on the bottom some corresponding labels of how the releases of these relate to the policy objectives that Matt has talked about, and sort of sequentially sort of raising the baseline floor of capabilities. So our work is not done. But if you're interested in this, I mentioned the DaVinci FHIR implementation, the FHIR Accelerator program as one. There's kind of a collection of accelerators, which are these communities of practice, these organizations who are committed to working together to solve problems where they realize, gosh, I like to do this, but I can't do it alone. I'd like to work together with technology vendors, if I'm a payer, to work with other provider organizations, et cetera. And so the Argonaut project, for example, has been one of the FHIR accelerators that really helps set the initial design patterns for the new versions of US CDI being reflected in FHIR. I mentioned the DaVinci FHIR Accelerator focused on payer and provider data exchange. Karen, who's given presentations here, focused on consumer-directed exchange. Codex, which has focused on creating profiles for common data elements in oncology, now in cardiology and genomics. The FAST FHIR Accelerator, which kind of grew out of work that ONC started under their sort of convening, now is a FHIR accelerator that is really sort of wrestling with and developing solutions for these infrastructure and scaling initiatives where thinking about, well, point-to-point FHIR exchange is great, but as we sort of think about bringing that up to national level exchange, what are the kinds of challenges that we will face and what are the solutions that we may need? The Gravity project is focused on exchange of social determinants of health. Helios, as Matt mentioned, is one of the accelerators really focused on enabling public health data, and Vulcan is focused on the interplay between clinical research and clinical care data systems. So that sounds like a lot, and maybe you're wondering, gosh, I'd like to learn a little bit more. Where might I do that? What if my developers need to sort of scale up on their FHIR knowledge? Where might I go for that? And I'll just point you to the HL7 website. There's a hl7.org/learn more with a whole bunch of different opportunities for education, both synchronous and asynchronous, depending on what perspective you're coming from. So in closing, I want to sort of take a glimpse ahead and think about the evolution of FHIR, dating back, now more than a decade old. This upper level graphic shows the major releases of FHIR over time with all the different resources as these little cells. And you might know, if you're sort of a FHIR nerd, that each one of those resources is graded according to a maturity model that talks about how well used and how sort of stable it is. And what you can see over time is that the content in FHIR continues to be progressively matured and undergoes ongoing curation. And so while we're at release 5, just on the horizon, really, and within the standards development community, we're sort of hard at work on FHIR Release 6, which we've designed to be, and are sort of setting the expectation to be, a major milestone release, where we try to take as many of the core clinical resource types as are in FHIR to that fully normative, that sort of top level maturity to serve as sort of the next sort of platform for innovation and development. So if you're curious about where FHIR is going, definitely check out HL7, and we'd love to have you participate. And with that, I'll say, this work is only possible because of the contributions and the perspectives of all of you. This is not a government-driven thing. This is a community-driven thing, and there's lots of opportunities to engage. So with that, thank you. I think we have a couple of minutes for questions if folks would like. So thank you.
Yeah, and if you don't want to ask it in front of everyone, we can go to the side. I'll be around.
All the hard questions go to Matt.
Oh, geez. Julia, what's up?
Julia.
So FHIR API is a great way to send and receive data, but as a physician user, that doesn't mean that information is made available to me in the interface. Is there a thought about how to promote sort of write back capability of FHIR and APIs, and a consideration as to whether or not that might be a future certification criteria?
So we've discussed about it, but not immediately. It's not something that's immediately coming down. We are trying to work on, consistent, what we call HTI1, HTI2, potentially HTI3s. So there is this ongoing ability to move forward. We do have the standards version advancement process, which potentially could be a way to, move forward to new versions. But as far as we don't have any right now plans to do that. But that's something that we've been discussing.
Yeah. The only thing I would add is, within the FHIR community, I think the Argonaut Accelerator is probably the place where a lot of that thinking is going on. It's a lot about the workflow of how that data sort of comes in and gets visualized, and who might need to approve it, et cetera. But there's a current project this year focused on FHIR Write for a couple of key data elements, blood glucose, and I'm blanking on the next one. There's two.
Forget what it was. Oxygen, maybe?
Yeah.
I'm blanking on Anish said it yesterday.
Yeah. But it's reasonably well circumscribed, and the point is to try to get a pattern that could then be applied to other data elements.
We have 1 minute and 7 seconds left. Anyone else want to? Of course.
There are a lot of people at Vive and places in the industry who are interested in using APIs to connect multiple products into a single electronic health record, for example. But I think there's a lot of concerns and confusion about what that can and should cost and how to successfully do that integration. So do you have any comments or tips for folks?
In our rules, we do put how much it theoretically should cost to make updates to the the standards we require. You're putting me on the spot with this one, but in our rule, we do say specifically what we think it should cost based on research that we've done to update your products to the new versions of standards. So Do you have anything to add?
No.
Yeah. I mean, I know I do know that it is of concern, especially some of the work we've been doing with the with HRSA and the federally qualified health centers on their ability to be able to update their systems and stuff like that. So that's something we're always thinking about and making sure that it doesn't cost too much. So we don't want to make burden for the underserved community and pretty much anyone, but still.
Right. Yeah, I mean, certainly that is the goal. And I think there are a few sort of scaling issues that things like TEFCA can help address, which is sort of how do you do like app registration sort of at scale across things, which helps. But I've heard similar things. I've also heard, it's challenging to sort of figure out how to really get across all the different platforms, et cetera. But certainly that's exactly what the standards-based APIs are meant to help with.
It keeps repeating. Like now it actually went. Now it's going up. All right. Thank you. Appreciate it.